Good afternoon, all. Now we will start our next section, challenges in glaucoma management. My topic is choices and challenges of treatment in first-time diagnosed glaucoma. Aim of glaucoma treatment is to control the IOP so that further glaucomatous damage is prevented and patients' vision-related quality of life is stable. IOP is the only modifiable risk factor. The ocular hypertension treatment study randomized patients into medication and non-medication group. And after 5 years of follow-up, medication group progressed for 4.4% in the medication group progressed, while 9.5% in the untreated group progressed. The early manifest glaucoma trial, early POAG patients were randomized into treatment and non-treatment group, and after 6 years of follow-up, progression was seen less in treatment group. This emphasized the importance of controlling the IOP in glaucoma. There are different challenges faced by the treating physician. Early diagnosis itself is a challenge, as most of the patients come very late in late stage of disease, and reducing IOP and controlling fluctuation is most important for controlling further damage, and we have to select the best suitable treatment, which is another challenge for the treating doctor. There is poor quality, the quality of life of these patients are affected, as the diagnosis itself is will affect the patient, and the treatment with the cost and side effects also affects the patient. And complaints of the treatment is another challenge faced by the treating physician. IOP can be lowered by medication, lasers, and surgery. The risk and benefits of the treatment should be discussed in detail by the treating clinician and the patient. There are several factors to be considered before starting treatment. The patient-related factors include the severity of the glaucoma, whether the degree of visual field loss, whether one eye or both eyes are involved, the degree of IOP lowering required, effect of past treatment, and any concurrent systemic comorbidities. And the cost of the treatment and availability of the treatment like SLT should be taken into consideration before starting treatment. We have to set a target IOP before starting treatment. The target IOP is the IOP at which further glaucomatous damage is prevented. It is based on the pre-treatment IOP levels, severity of visual field loss, risk factors for progression, life expectancy, and potential for adverse effects from the treatment. We have to stage the patients into suspect, early, moderate, and advanced stages of glaucoma depending on the these changes and the visual field defects. And for suspects, we have to reduce the IOP by 20% from the baseline. In early glaucoma, 25%, moderate 30%, and in advanced cases, 40 to 50% reduction of IOP is needed. So, topical medication is the first line of choice in most of these cases, and the ideal drug should control the IOP effectively. It has a tolerable safety profile, it is associated with a stable visual field, and it improves the orbital microcirculation. The first line of drug of choice in most cases are prostaglandins, as it has a superior efficacy, once daily dosage, and with minimal systemic side effects. Beta blockers can also be used as first line choice, but it is less effective compared to prostaglandins, and it has systemic side effects. And brimonidine reduces the IOP by 20 to 25%, and carbonic anhydrase inhibitors by 15 to 20%, and this can be used as the second line of treatment. So prostaglandins reduce the IOP by 25 to 35%. And coming to the pitfalls, the adverse effects of the topical glaucoma treatment is the main cause for withdrawal of this medications, and vision related quality of life is affected as because of the dryness of the eyes, and most of the patients require more than one eye drops, and putting drops will be a lifelong commitment. The compliance of the treatment can be improved by giving good counseling regarding the nature of the disease and the importance of putting medications. Fixed drug combination should be used whenever possible, and if there is any budget restriction, cheaper but equally efficacious drops should be used. Selective laser trabeculoplasty is another first-line treatment. It can be used in early and moderate glaucomas and in ocular hypertension. It achieves IOP reduction comparable to the drug therapy. It's cost-effective. It's an outpatient procedure, but the laser in glaucoma and ocular hypertension treatment trial showed that selective laser trabeculoplasty can be offered as a first-line treatment for open-angle and ocular hypertension, supporting a change in clinical practice. A recent article in IJO showed that SLT can be used as a relatively safe and effective procedure in Indian eyes with open-angle glaucoma. Microincisional glaucoma surgery is another first line of choice. It can be used in early and moderate POIG patients where lesser degree of IOP lowering is required. It can be performed along with cataract surgery, and the advantage is it is a non-penetrating procedure, but the degree of IOP lowering is less than that of trabeculectomy. It is a limited long-term follow-up data. In advanced glaucoma, trabeculectomy can be considered as the first line of treatment. In advanced glaucoma intervention study, progression is least when the IOP is below 14 millimeter mercury. In UK, NICE guidelines suggest patients with advanced disease to be offered trabeculectomy as a primary intervention. Primary trabeculectomy for advanced glaucoma trial concluded that primary trabeculectomy achieved a lower IOP compared with primary medication, and it has a similar quality of life and safety outcomes to primary medication. So in conclusion, multiple treatment choices are available for newly diagnosed POAG and OHT patients. The decision on to which to choose is multifactorial, requiring input from both the patient and treating clinician. Treatment should be individually tailored to the patient. Relevant risks and benefits should be considered and discussed. And management paradigm has shifted towards minimally invasive, personalized, and adherence-friendly solution. Thank you. Now, I would like to invite Dr. Girija for her presentation on shallow AC with uncontrolled IOP post-YAG-PA.
Good afternoon, everyone. The topic given to me is shallow anterior chamber with an uncontrolled IOP post-YAG-PA. It's a common situation that many of us face. A patient with acute angle closure comes to you and you do a PI, but the IOP doesn't go down and the AC also remains perpetually shallow. So a 50-year-old female who attended our casualty with severe pain, headache and vomiting, all features of an acute angle closure, she gave a history of 1 week treatment from elsewhere with maximum anti-glaucoma medications and also systemic antiviral. And the affected eye had a vision of only 2/60. And the clinical features fit in with acute angle closure. The other eye had a shallow AC and she was admitted and treated conservatively, and YAG-PI was done in the other eye. And this eye had severe inflammation, so we waited for some days. And 1 week later, and we attempted a PI 2 days later, but it was unsuccessful. So it was repeated 1 week later, and we could do a complete PI. And IOP remained high, and the patient was discharged, but patient came back with there was PAS formation. So, and the symptoms also had returned. She was asymptomatic in between, that was for a 1 week or 10 days period, and the IOP had gone very high. So she was posted for TRAP, and now the post-op IOP is 12 millimeters. So YAG PI is performed to relieve the pupillary block in an acute attack. And usually after an PI, there is equalization of pressure, the IOP comes down, the iris flattens, and the AC reforms. But this does not happen in all cases. Sometimes the AC remains shallow. So this is a case of pupillary block where after a PI, you can see that the iris has flattened comparatively and the AC has deepened. Whereas this is a case of plateau iris where the angle closure, actually it is continuing to be there and the AC is shallow. And this is a mixed mechanism where also the AC is shallow. So what are the reasons for the high IOP post-PI? So it can be due to an incomplete PI. It can be due to a closure of the iridotomy which was patent due to some inflammatory debris or pigments. And it can be immediately after the PI, there will be a temporary spike. I think everyone is aware of that, and we have to give usually we give brimonidine drops immediately after the PI. But when the patient comes back after some time, you have to check for patency in all cases of PI. And you have to think about if the AC remains shallow and the IOP is high, then you have to think of other mechanisms that is other than pupillary block, like any plateau iris syndrome, anterior rotation of the ciliary body or extensive PAS. So think about all the DDs like plateau iris configuration, the malignant glaucoma, anterior rotation of the ciliary body, which can be due to inflammation, drugs, masses, suprachoroidal hemorrhage. So a UBM or a B scan can help you in differentiating. And lens-induced mechanisms also have to be kept in your mind. And always think about the anatomical risk factors, mainly lens-related. So the acute angle closure, I won't go into the details of symptoms and signs. So always the definitive treatment is LPI, which helps to relieve the pupillary block and will prevent the future angle closure episodes. So if the iridectomy cannot be done in the laser, sometimes the patient may be uncooperative, severe corneal edema may be there, and if the IOP remains high, you can go for a surgical iridectomy, but it will be very difficult to do in such a situation. So it's better to wait for the inflammation to come down and then decide on whether to go for a surgical PI or a TRAB. And lens extraction, again, if there is severe significant anatomic risk factors like very high lens thickness or an increased lens vault. And if PI is successful and if the IOP has come down, every case has to be followed up periodically like any other glaucoma case. And these are all the surgical treatment options. And in angle closure glaucoma, whenever there is an inadequate IOP control and if the PAS formation is continuing or if the disc changes or the field changes are also progressing, or never wait and you have to go for a trabeculectomy with if the at least 3 anti-glaucoma medications have been tried. And there may be sometimes you have to do a TRAB in case of poor compliance because many patients nowadays develop allergy or intolerance to anti-glaucoma medications. And you can go for a trabeculectomy. And doing a trabeculectomy in an angle closure eye is always challenging because the AC is very shallow. Even a PI may be very difficult. So you have to be very careful. But you have to do a PI in so large surgical PI is a must in trabeculectomy. And always use mitomycin C. And these are few precautions that you can take. Always reduce the IOP because high preoperative IOP usually will result in a high postoperative IOP also. So reduce the IOP with Diamox, mannitol, and you can even stop the anti-glaucoma medications topical and you can start with Diamox and bring down the IOP. And if antimetabolites are being used, you have to take the precautions. And paracentesis, always never cross the pupillary margin because you can accidentally touch the lens and can result in cataract formation later. And keep the target IOP in mind when you are preparing the ostium. And releasable sutures always help you to prevent the complications like hypotony. So you can release them if the IOP is high. So, and careful post-operative care. You have to counsel the patient before that it may be required to frequent reviews may be required. So, this is a case of PIS, plateau iris syndrome. So, after an LPI, the patient came back with a high IOP just like an acute attack, and the gonio showed a double hump sign. So, a diagnosis of plateau iris syndrome was made, and you can see the double hump sign. So, it has to be treated with, you can treat with anti-glaucoma medication because the LPI is already there. So, you can go for anti-glaucoma medications, and a low dose pilocarpine can help in such patients. Even a cataract is present, then cataract surgery can help. Aqueous misdirection syndrome when the AC is uniformly shallow. So, in plateau iris syndrome, the central AC is deep, but here uniformly shallow. It's usually seen after surgical procedures like trabeculectomy or any other surgeries, and usually occurs in short, small eyes, like short axial length. And the treatment guideline, cycloplegia is the most important thing along with aquosuppressants. So that has all the treating a malignant glaucoma is very difficult, but if you give them correctly, it resolves in 5 days, and you have to continue the cycloplegia for a long time. And a PPV may have to be done as a definitive treatment later. And this is a case that underwent phacotrabeculectomy, but 1 month later, the patient presented with features suggestive of malignant glaucoma. And later, we did a YAG capsulotomy plus anterior hyalotomy because it was a pseudophakia. But if it is a phakic eye, it may be difficult. So, in all cases, always look for take a careful history, ask for any surgical procedures, do a careful examination, and reach a diagnosis. And always check for PI patency and AC depth after a YAG PI. Thank you.
Thank you, ma'am, for that informative talk. Now, I would like to invite Dr. Mahesh Bharati for his talk on intractable neovascular glaucoma.
At the outset, I would like to thank Ksos Scientific Committee and Dr. Smitha for giving the opportunity. I would be talking about neovascular glaucoma, which itself is refractory, and the topic is intractable neovascular glaucoma. And we being in the diabetic capital of India, all of us deal with diabetic patients and neovascular glaucoma, whether it's a glaucoma person or a VR person. So the outline would be about a short introduction and a pathophysiology, the principles of management, and evidence-based surgical options that are available, and a summary. So as I said, it's a refractory glaucoma, and the major causes are, whenever we ask a PG student, they tell diabetic retinopathy, CRVO. It's proliferative diabetic retinopathy, ischemic CRVO, and the third important cause is a carotid artery occlusive disorder or ocular ischemic syndrome, and even chronic uveitis. And the pathophysiology, as all of us know, is the hypoxic retina, which generates the vascular endothelial growth factors, and they cause neovascularization of the disc or elsewhere, and which percolates through the pupil and comes into the anterior chamber and causes NVI and also NVA in the angle, which grows on to form fibrovascular membrane, which can physically obstruct the aqueous outflow in the open angle stage or close peripheral anterior synechiae and cause a zipping angle closure and cause closed angle stage of neovascular glaucoma. I'm talking about the four pillars or principles of managing neovascular glaucoma. We have to absolutely take care of the underlying systemic disease and then take care of the treating underlying ischemia, control the inflammation, and then comes controlling intraocular pressure. We'll leave the rest and we'll focus on managing intraocular pressure. So as I told, it's a refractory to medical management, needs aggressive, multimodal and multi-speciality care. And the surgical options that is available to us as of now are augmented trabeculectomy, glaucoma drainage implants, and cyclophotocoagulation. So let's go into each of it. Trabeculectomy has been the gold standard, but especially in neovascular glaucoma, it has a high risk of failure because of extensive fibrovascular proliferation, inflammation, and scarring. So we talk about augmented trabeculectomy, and the options available to us as of now are mitomycin C and 5-fluorouracil. Ologen is not available anymore. And with the advent of anti-VEGF drugs, anti-VEGFs have played a major role in reducing the vascular proliferation in post-neovascular glaucoma and decreasing the fibrosis, and using releasable or adjustable sutures to titrate the bleb. Now, looking at a major retrospective study conducted by my mentor at our alma mater at LV Prasad, where they looked after the surgical success of TRAB and with respect to the causes. The success of TRAB is best among the three in ocular ischemic syndrome compared to ischemic CRVO, and then it's the success is reduced in proliferative diabetic retinopathy. And the risk factors for failure that was noted were older age and a persistent neovascularization of the iris, a need for higher anti-VEGF injections before going for trabeculectomy, or doing a delayed surgery. All this led to a increased failure of trabeculectomy. Now we have a choice of, there is been a debate whether trabeculectomy with MMC or can we use trabeculectomy with anti-VEGF in the subconjunctival space. So a couple of major randomized controlled trials published in the Journal of Glaucoma, they talk about subconjunctival bevacizumab is safe and effective in controlling intraocular pressure. But over 1 year and 2 years follow-up, mitomycin C augmented trabeculectomy has always been superior than subconjunctival bevacizumab. The mode of delivery here discussed is subconjunctival bevacizumab, either as injections or sponges. Now, what if, so we can conclude in the previous one that MMC is superior to subconjunctival VEGF. Now, what if we add bevacizumab, which is an adjuvant anti-VEGF, to a TRAB with MMC? So, the bevacizumab in trabeculectomy study tells that adjuvant anti-VEGF is beneficial either in the intracameral space or in the intravitreal space. It reduces the MMC related complications, improves the survival of the bleb and its morphology, especially with respect to thin cystic blebs, and the bleb related complications are less seen when we give intravitreal, single dose of intravitreal bevacizumab along with a trabeculectomy with MMC. Going on to the next available options, we have the glaucoma drainage implants. We have the Ahmed glaucoma valve, or the non-valved implant, the Barwell glaucoma valve, or the Indian prototype ADI, Orolab aqueous drainage implant, and the latest ADI 250, or the non-valved Ahmed's compatriot, which is the Ahmed Clear Path, and the Paul glaucoma implant. So, as we know, valved glaucoma implants are indicated when we need early postoperative IOP control, and they have a less chance of hypotony, but they come at a cost. Whereas the non-valved implants, they have a delayed but prolonged IOP control. The risk of hypotony is there, but can be prevented with modifications. They are cost effective. No financial disclosures here. This is a recently done ADI 250 with where the surgery has been, very easy. I didn't have to dissect the muscles because the size is small, which can be kept in between the intramuscular spaces between the superior rectus and the lateral rectus. And the tube has been occluded by a 3-0 proline suture and also the ligated with 8-0 Weichel. So, can we augment the glaucoma drainage implants also with anti-VEGF? Again, two major randomized controlled trial and a meta-analysis which says that the success rate of Ahmed glaucoma valve, here they have studied only the intravitreal bevacizumab with respect to Ahmed glaucoma valve, which improves the success rate, reduces the complications, and reduces the aqueous humor VEGF levels, which extrapolates to tell that the hypertensive phase of AGV can be reduced by giving an intravitreal bevacizumab and reducing the aqueous humor VEGF quantity. Now that we have AGV and non-valved implant, which tube to go for? Again, a RCT and a retrospective multicenter trial, which says that both AGV and Barwell have a comparative outcomes, whereas the surgical success in this multicentric retrospective study says that Barwell glaucoma implant has a very high success rate, especially at 1 year, 2 year and 5 years. And the post-op complications rates are similar, but the need for reoperation is excessively more in AGV as compared to a Barwell glaucoma implant. Can TRAB be better than tube? So what is the TRAB versus tube comparisons say. Similar surgical success is seen both in TRAB and tubes, IOP reduction, visual acuity, and number of medications at the last visit. But this multi-center trial, which says compared between the outcomes of tube, especially the BGI, bare-wall glaucoma implant, and trabeculectomy, especially in neovascular glaucoma, they claim that the bare-wall glaucoma implant has a higher success rate, similar post-op complications, but the rate of reoperation has been more in TRAB as compared to tube. A short note about cyclodestructive procedures usually used as the end-stage disease for pain relief. With the advent of micropulse CPC and the endoscopic cyclophotocoagulation, they are nowadays considered in the early stages, or if patient is unfit for glaucoma filtration surgery. And it's claimed that endoscopic cyclophotocoagulation via anterior route via endoscope target ciliary processes, and to achieve a 30% reduction in intraocular pressure, a 3-quadrant ablation is needed. A quick take clinic message would be, it's a highly complex secondary glaucoma requiring multimodal and multidisciplinary care. Management of underlying pathology and ischemic retina remains the mainstay. Effective control of inflammation is an essential adjuvant in the management of NVG. Though trabeculectomy has high risk of failure, adjuvant TRAB can survive longer, and adjuvant anti-VEGF with TRAB MMC increases the survival, improves the morphology, and reduces blood-related complications. Despite the TRAB versus tube debate, a well-planned anti-VEGF augmented trabeculectomy is worth considering, especially in eyes with pristine conjunctiva. Non-walled tubes offer a superior long-term IOP control with fewer medications, provided post-op hypotony is carefully mitigated. And cyclodestructive procedures, traditionally reserved for end-stage NVG, is increasingly being used in the earlier disease stage also. Thanks to my mothers in glaucoma and my alma mater both at LVPI and JIPMER, and thanks for a patient hearing. Thank you.
Thank you, Dr. Mahesh. Now, I would like to invite Dr. George Puthudan for his talk on intra and postoperative challenges in GDD implantation.
Thank you and good afternoon. So I will just try to cover a few intraoperative and postoperative challenges in GDD implantation. So superior temporal quadrant is the most preferred quadrant for placement of the episcleral plate of the aqueous drainage implant, and is the most comfortable for the surgeon. But sometimes intraoperative surprises can occur. This is a post-vitreoretinal surgery where when we dissected out the conjunctiva, the previous entry site of the scleral port, the conjunctiva has become a buttonhole. So we had to shift superior nasal for implantation of the tube. Another patient, a young child, had peripheral anterior synechiae along the supratemporal quadrant. Again, the tube is placed in the superior nasal quadrant. So surgeons have to be mentally prepared to alter the quadrant, and superior nasal quadrant is not difficult to work with. It is just a question of your mental makeup. You just shift superior nasally and you can do the surgery. Sometimes the whole of the superior quadrant is compromised for placing your tube in the superior quadrant, and here it becomes challenging to place it in the inferior nasal quadrant. So this is also a skill which glaucoma surgeons need to know. The issues here is the nasal brow makes it difficult for the tube, for the needle entry into the anterior chamber, and also anywhere in surgery you are working away from you, and here you need to pass the needle towards you to get into the inferior nasal quadrant. We found that burying the tube in the patient's own sclera in a 23 gauge needle generated 4 millimeter long scleral tract tremendously reduced the incidence of tube exposures in our patients. It is challenging to get the tube in a good position in the anterior chamber when you have such a long scleral tract. But you should always know, while making a slit, you need to maximize the distance of the corneal slit from the tube slit, and the tube slit should be as close to the iris as possible, and this rule should obey right from the tube entry site into the anterior chamber. find ways to make it work in your hand. We did some certain calculations. Our scleral track is 4 millimeter long. We found that the 23 gauge needle has a 2.8 millimeter and then a 2.3 millimeters. So we roughly found that till 2.8 to 3 millimeter of the scleral track traverses the sclera, parallel to the sclera, and then you have a mental judgment of where exactly you need to dip into the AC. Then don't go any further. If you go any further, you'll get into the cornea. I have a small animation to explain this. It's about the initial track you enter into the 4 millimeter scleral track. And if it's a very deep AC, you can afford to dip into the AC as soon as 2.8 millimeters of the needle has entered the sclera. If it is a phakic eye, probably you will have to enter the sclera 3 millimeters before you dip it into the, and as you dip into the AC, you rotate the eyeball towards you so that you can see the needle entering the eye close to the iris. There is a difficulty sometimes that tube may not get into the anterior chamber very easily through these close-fitting scleral tracks. One thing we learned is if you depress the sclera at the site of that transition, the tube enters into the anterior chamber. Sometimes there is insufficient space in the anterior chamber for placement of tube in the AC, especially in post-PKP, and if there's a post-DMEC eye where you need to place the tubes into the ciliary sulcus. An important point to note here is you need to have your bevel down, or at least your bevel face sideways for sulcus placement. If it is anterior, is every chance that the iris is going to block the tube and the tube function is going to be compromised. So ideally, you need to just see the tube when the pupil is dilated. It needs to be facing side, and you enter the scleral groove. You enter the scleral groove with the bevel facing down to have the tube come into the anterior, into the ciliary sulcus at least sideways. Sometimes it's just not possible to place the tube in the anterior chamber or in the ciliary sulcus. You will have to do a pars plana tube insertion. For this patient who had very bad iridocorneal endothelial syndrome, near flat AC, we had to do a lens-sparing pars plana vitrectomy to place the tube in the vitreous cavity. Sometimes you encounter patients like this with compromised cornea, and the patient has already undergone multiple vitreoretinal surgeries. So this is also a situation where you could afford to place the tube into the vitreous cavity. But a prerequisite for pars plana tube insertion is to have a complete anterior vitrectomy. Otherwise, definitely, even you need to have a good vitrectomy surgeon shave off even the peripheral base of the vitreous. Otherwise, some kind of vitreous strand is going to come and block the tube. You also encounter pre-existing episcleral hardware, but believe me, these episcleral bands, 360-degree episcleral bands which the vitreoretinal surgeon uses, they have a nice fibrous capsule around them. It doesn't get scarred to the conjunctiva overlying it. It is very easy to, it is not difficult to dissect out this episcleral band from the overlying conjunctiva. The difficult part is the areas where the vitreoretinal surgeon has made the scleral ports. That is where you have to be very careful because there is scarring there. And you can also hope that the vitreoretinal surgeon has put the tenons and the conjunctiva back and have not thrown it away. So it's possible to place the episcleral plate beyond the band. It is possible to suture the episcleral plate onto the band. And sometimes on a very rare occasion where the episcleral band is very posterior, you can even afford to remove the episcleral band. You can easily nick the fibrous capsule and it just comes out. The point you need to consider is you need to avoid areas of and there is a difference between an episcleral band and a buccal. Buccals are 8 to 9 millimeters in diameter. So vitreoretinal surgeons actually place buccals nowadays only in the areas of breaks, and they do an encerclage with a episcleral band. So you need to have a good preoperative evaluation to know where they have kept the buccal and avoid that area for your placement of your episcleral plate. Coming to the post-operative challenges, one thing that is very common, or at least not rare, is that you can have shallow chambers post-GDD surgery, which may be due to transient choroidal effusions, and most often times they recover with conservative treatment. Two things to be taken into account here. In non-valved implants, you need to have complete tube occlusion. As Mahesh was mentioning, you need to have either a 3-0 or a 4-0 intraluminal stent. ACP comes with a 4-0 nylon. RD Orolab has a 3-0 multifilament, which is trade name is Supralon. And you also need to have complete occlusion, one over the Supralon and one beyond, Vicryl sutures. You cannot afford to have hypotony in GDDs. You don't need the tube to function for 6 weeks. That is fine. But once you have some little bit of leak, then it's going to be very difficult. The next thing is, see the track in the first picture. It's a very superficial track. And a surgeon has tried closing the track on either side of the tube, which means they had difficulty in forming the AC. So see the second track which has been made. So the scleral tracks also have to be of adequate scleral depth so that the tube is buried in the sclera, at least about 50 to 60% of scleral thickness. Tube blockages, blood and fibrin resolve spontaneously. Tube blockages with vitreous are troublesome. Nowadays, we just give it to the vitreoretinal surgeon. They do a wonderful pass. Whatever anterior vitrectomy you do, I don't think that's the way to go. Vitreous keeps coming out. Pars plana vitrectomy, they easily remove it. And sometimes it can be subtle. See the first tube, that lumen is not transparent. There is some whitish material inside there. That is vitreous blocking the tube. Again, tube blockage with iris, this is easy. You can just sweep it. This was swept while doing cataract surgery. And this is also an elegant method where this tube in the sulcus at the PI site has somehow migrated, and very high pressures, iris has been sucked into the tube with a compromise in the outflow. So you can have your vitrectomy. You need to know where that you can feel that area with the cyclodialysis spatula, and it is relatively simple to just make an opening just above the tube to visualize and make it free from the So this is something which now, because of intraluminal supralon stenting, we are not worried when the patient comes in at 6 weeks post-op. Sometimes for very high risk vitrectomized aphakic eye, when the Vicryl suture gives way, it can cause suprachoroidal hemorrhage. So now this has become much more safer, and tubes cannot be left close to the endothelium. Repair of tube exposure and tube retractions, I don't think are beyond the scope of this lecture. And superior nasal quadrant is preferred location. We have seen that tubes in the maximum complications in our long-term results were the tube retractions in children and tube corneal touch in adults. Tenon cyst and encapsulated bleb continues to be a major problem with the Ahmed glaucoma valve. And to conclude, not all battles can be won, but I don't think we should be accused of not trying enough. Thank you very much. Thank you, Dr. Smita and Ksos for the opportunity. I forgot to say.
That was an excellent presentation, Dr. George. Now we are moving on to Dr. Roni's presentation. Unfortunately, he is unable to come, and he has sent it on as a recording of the presentation. Tackling the thief of sight in children. Thank you, Dr. Roni.
Good afternoon. Apologies for not being there in person, and I thank Ksos and Dr. Smita for including me in this IC. I'll be speaking to you briefly about tackling glaucoma in children. So I'll talk to you a little bit about classification, how you evaluate them, and general principles about assessment and management. So the CGRN classification is what we use now to categorize glaucoma, and it's fairly simple. It basically says that if you have an intraocular pressure of more than 21 millimeters of mercury, cup-to-disc ratio asymmetry of more than 0.2, focal thinning of the optic disc, the presence of half stray, corneal edema, or increased corneal diameters, axial myopia, or a visual field defect. If you have any two of these, you could consider these patients would be considered to be glaucoma. Or if over longitudinal follow-up, you are demonstrating increased cup-to-disc ratio or progressive myopia or increasing axial length, you would consider classifying these patients as these children as having glaucoma. So keep in mind that the normal values for children are not the same as for adults. So the corneal diameter of any neonate, if it's greater than or equal to 11 millimeters, within 1 year greater than 12 millimeters, at any age greater than 13 millimeters, is considered abnormal, and intraocular pressure at a young age is likely to be low. In fact, at the age of 12 to 16, your normal intraocular pressure may be up to 16 and not really much higher than that. So anything beyond that should be considered to be suspicious. Primary congenital glaucoma you would categorize if as neonatal, infantile, or late onset, or when the age of onset is unknown, we would not know about it. I'll talk to you about the other three common categories that we see frequently. When you come to the congenital glaucomas, while the epidemiology suggests that you see it in 1 in 10,000 live births, in India you do see it a little bit more frequently than that. While most of them are isolated, approximately 50% of them you will find a genetic defect if you test for them. They're more commonly male and they're more commonly bilateral. And the etiology is because the angle fails to develop properly and this cleavage doesn't happen. And the reason why I'm emphasizing this is because the very, very important part of clinical evaluation is gonioscopy. Because a flat or an anterior iris insertion tells you that that angle hasn't cleaved completely. Or a concave insertion where you have a lot of anterior stromal trabecular meshwork also tells you that that angle hasn't cleaved completely. So gonioscopic findings are very important when you try to assess what is happening in these children. The classic triad of watering, blepharospasm, and epiphora occur because of the corneal changes, because of corneal tears. But sometimes you can see a fairly quiet eye where corneal enlargement is the only sign. And these children are the ones that we have to be careful of not missing. It's important that any child who has suspected glaucoma undergo a complete evaluation and an examination under anesthesia. And whenever you do an examination under anesthesia, measure the intraocular pressure as soon as the child is quiet, preferably with a Perkins tonometer. For us, routinely, we would do an external exam, refraction, measure the corneal diameters, do a slit lamp evaluation using a handheld slit lamp, do gonioscopy, do a fundus evaluation, document the optic disc if you can, and definitely check the axial length. These are more or less the minimum things that you need to do. You can try, keep in mind that different anesthetic agents have issues in terms of intraocular pressure reduction. Also keep in mind that the axial length in these children increases dramatically in the first 1 year, and that should be kept in. So you can actually document the gonioscopy in a child if you have a red cam with a with a high power lens, and that can sometimes be useful, but most of these children have pretty bad corneas, so it's really not always as simple as it looks in this picture. The optic disc, again with a handheld camera, can be documented, but again corneal changes can make that challenging. So congenital glaucoma is a surgical disease, and generally you have multiple surgical options. The first option is usually a goniotomy or an external trabeculotomy. You might combine that with a trabeculectomy with antimetabolites. You could use aqueous drainage implants, or you could use ciliary ablation in a very poor prognosis eye. So for us, our usual protocol is that if the age is less than 2 years and the corneal diameters are less than 13 millimeters and the cornea is clear, we would try to do a goniotomy alone. If the cornea is hazy, we would do a trabeculotomy alone. If it's not these criteria, then we would consider doing a combined trabeculectomy and trabeculotomy as our first step. They require multiple follow-up evaluations, and at follow-up evaluations, all these things need to be monitored to make sure that we're not missing anything. And the endpoint, of course, is normalization of the intraocular pressure, clearing of the cornea. You do see reversal of optic disc cupping and stabilization of axial length too. So the second common category is glaucoma following cataract surgery. And it's important that you document what the cause of the cataract was, because some of these causes are associated with greater risk of um, glaucoma anyway. In our own series of about 104 children who underwent gonioscopy before they underwent congenital cataract surgery, you found that 9 of them had actually abnormal angles. So about 10% of those eyes had abnormal angles at presentation itself. And one of these eyes developed glaucoma in the follow-up. And this is over about a 2-year follow-up. So the disease itself can predispose to increased risk of glaucoma with time. And generally the eyes with anterior iris insertions tended to be smaller, corneal diameters but larger axial lengths, and tended to be younger. So basically what we're saying is that these are eyes which are anyway anatomically slightly abnormal and therefore greater risk of glaucoma. The treatment protocol for these eyes is surgical, topical medications first. Surgery very often, since they're aphakic, emet glaucoma valves probably our first choice. If they're pseudophakic, then we would consider trabectectomy with mitomycin. Angle anomalies, if they are present, angle surgery is one option that you can consider here. I'm not going to talk to you about the other acquired conditions like trauma, steroid-induced NROP, because their management is very similar to what you see in an adult. But I will talk to you a little bit about the glaucoma associated with non-acquired systemic diseases. For example, the image on the top left is one from neurofibromatosis. So these children are at greater risk for glaucoma. You do see the ectropion uvea and the lesion nodules there. And it can be a little difficult to treat because the angle tends to close up. And these are eyes which are treated like any other secondary glaucoma, but you also get somebody like this with the Sturge-Weber syndrome who is at a much greater risk of glaucoma. And these children, whenever you're doing surgery, you have to remember there's a high risk of choroidal effusion, and you may need to think in terms of a prophylactic sclerostomy when you do it. The images on the bottom are from basically examples of glaucoma associated with non-acquired ocular anomalies. Some, like the image on the left, where you have microspherophakia, may require a lensectomy before you can actually tackle the glaucoma, because that lens is going to come forward and cause problems. In between, like you see, this accent field anomaly. Now, there's nothing that you can do for the accent fields anomaly, but you know that this is likely to be progressive, and these patients need to be monitored a little bit more closely. And this image on the right basically shows you a pupillary block because of a membrane. And here, unless you tackle the pupillary block, you are not going to be able to deal with the glaucoma. So in all these conditions, with the exceptions that I just spoke to you, medical treatment is the first line of treatment. Only in primary congenital glaucoma is surgery the first line of treatment. And when it comes to medical treatment, before you do that, you need to explain to the parents the nature of the condition, the fact that they require a long-term treatment, long-term follow-up. And also, it's worthwhile to talk about choice of profession once they're a little older, what for the future for these children. So whenever you do medical therapy, it should be done with punctal occlusion. In congenital glaucoma, it is only as a temporizing phenomenon until you do the surgery. The first line of drugs are betoxolol or timolol, preferably 0.25% twice daily. But keep in mind that they don't really develop a wheeze. They may present as a cough as a side effect, and that's something that you need to watch for. You can use topical dorzolamide, you can use oral acetazolamide for short durations. When you compare dorzolamide with timolol in children who are young, you actually see similar efficacies in both groups. And when you compare latanoprost with timolol in pediatric glaucoma, you again see similar efficacies in both groups. So these are the 3 drugs for which studies have been done and which have been shown to be effective in managing glaucoma. But still, our protocol is usually timolol or dorzolamide first, and then followed by latanoprost as a second line. Keep in mind again that the blood concentrations of all these drugs is much higher in children than in adults. And that's the reason punctal occlusion is absolutely essential. These are reports from 1999 which showed what happened when you use brimonidine in children. And these children went into apnea because it causes central nervous system depression. Even though there were multiple reports at that time, if you search the literature between 2000 and 2006, you will see at least another 6 cases where this happened. So brimonidine is absolutely contraindicated in children and should not be used even by mistake. Your job doesn't end here. You have to treat the amblyopia, you have to do cycloplegic refraction, you have to do occlusion. We need to do a PK if there are corneal issues. But pediatric glaucoma, if you can diagnose it early and preserve vision and prevent glaucomatous optic damage, you can actually manage to give them a good quality of life in the long term. But it takes a really, really lot of effort. And this is one patient who's had 26 glaucoma procedures or ocular procedures. And now she's 30 years old. She has one eye with 6/18 and 6 vision, and she's functional. So that's the sort of effort that is required to take care of these children. Thank you once again, and apologies for not being there in person.
Thank you, Dr. Roni, sir. Now we'll wind up the session. Any questions? Thank you for attending.